very much, and thank you for inviting me to Athens, Alapa. I've thoroughly enjoyed my visit here. We'll spend just about 30 minutes thinking about the orthotic management of cerebral palsy before retiring for lunch. Just a brief overview of what I'm going to include in the talk. We're going to consider exactly what orthoses are and how they work. Then just reprise what problems occur with hemiplegia and how orthoses can help. We'll then just briefly consider whether orthotic intervention is effective. So the term orthoses is a relatively new term, derived, like so many words, from the Greek. In the last 50 years, to cover any externally applied device used to modify the neuromuscular and skeletal system, and it does that through the application of forces. So orthoses don't work using magic. There's no Harry Potter. They use biomechanical principles. And as has been described in the previous few presentations, despite my lack of Greek, I can see the pictures. It's the application of forces. There's two types of forces. Action forces are created by the gravity and the activity of muscles, and reaction forces oppose gravity and muscle action, such as the ground. And orthoses primarily work using reaction forces to oppose the deforming forces generated by, for instance, spastic muscles. If we think how orthoses work, if you consider trying to pass through a heavy door, as I did through that one earlier, it's much easier to do so if you apply a force as far away from the hinge as possible, then you need a relatively low force, than if you apply your hand at the middle of the door at a shorter distance. So when we're designing orthoses, we want to apply our forces as far away from the joints as possible. We don't want to hurt the children or patients, therefore we want to apply our forces over the maximum surface area. The larger the surface area, the lower the pressure. The opposite, the smaller the area, such as with a syringe, is more likely to pierce the skin. There's a variety of ways that people use to describe orthoses. The best and most accurate one is the one advocated by the International Standards Organization, which describes the joints that the orthosis crosses. Such as an ankle-foot orthosis crosses the joints of the ankle and foot, and we use the acronym AFO. Similar terms we use knee-ankle-foot orthosis for one that comes as high as the thigh and covers the knee joint, to get the acronym CAFO. There are, however, other ways of describing orthoses that can be somewhat confusing. For instance, you might hear the term hip abduction orthosis, giving you some idea of what the biomechanical effect is. You also frequently get orthoses that are named after a person or the place of the first use, such as the Oxford Lees head support. But that doesn't really tell you much about the orthosis, and in general should be discouraged. It's necessary to think, before rushing in and prescribing orthosis because you saw it in a lecture once, to think what it is you want your orthosis to achieve. And therefore you should really start with your treatment goal. What is it you want the child to be able to do that they can't do without an orthosis? If after defining that goal you can distill some biomechanical objective that can be overcome, then you can then go forward and design an orthosis to overcome those biomechanical problems and include it in your treatment management plan. Afterwards, of course, it's necessary to evaluate whether you've firstly achieved your intended biomechanical effect, and secondly, then achieved your treatment goal. The two are not the same thing. An orthotic assessment is much like any other physical examination with the family of the children with cerebral palsy, but most importantly I put at the top the family's expectations, and especially their preferences for treatment, because they will mediate the decision that's going to be made about treatment. In terms of the diagnosis for children with cerebral palsy, I'd encourage you towards the surveillance of cerebral palsy in Europe definition, which distinguishes in our instances unilateral cerebral palsy hemiplegia from bilateral, without distinguishing whether there's an upper or lower limb problem. In terms of measuring the severity of cerebral palsy, the gross motor function classification system is now the best established way for describing a child's ability to sit, stand and walk. We then look at the range of movement, muscle strength, etc., joint congruency, and also any associated complications such as we've described earlier this morning, and also take into account that orthoses are frequently not applied in isolation, they're part of an overall management plan. So what is hemiplegia? As you're quite clearly aware, it's a unilateral spastic impairment as opposed to bilateral spastic cerebral palsy, which would then include children with asymmetrical involvement, and that's quite important. Spastic hemiplegia affects about 30% of children with cerebral palsy, and all of them walk, barring any other impairments, which makes them GMFCS levels 1 and 2. It's, as Kerr Graham quite clearly points out, it's the impact of the bone growing in the presence of the neuromuscular impairment that leads to structural deformity. So as all the children can walk, quite clearly we're interested in how well children can walk. It's not that they need an orthosis potentially to help them walk, it's to help them walk in a different way. And these prerequisites of normal gait were defined firstly by Jacqueline Perry, that you need stability in the stance phase, clearance in the swing phase, appropriate pre-positioning, and adequate step length and conservation of energy. I'm sorry, can I get a glass of water? An old habit of drying up. So if we consider the first problem of stability in stance, for the most mildly affected children, one might get away with something as simple as a heel cup, some sort of foot orthosis, to hold the arches of the foot in a better posture. Now, Winter's classification has been mentioned in the previous couple of presentations, and it's a sagittal plane classification system for gait deviations, with 4 types, with increasing severity associated with increasing proximal impairment. And as has been described, type 1 involves merely a foot drop in swing, equinus in swing phase, which can be overcome using a posterior leaf spring AFO. Because the AFO is trimmed very narrowly around the heel, it's incredibly flexible. It's sufficiently stiff, however, to prevent plantar flexion, but to allow dorsiflexion and also some rotation in the transverse plane. Children with type 2 problems have equinus in stance and swing phase, and the consequent knee hyperextension. The solution for this problem is a rigid AFO, which, as you can see, applies a 3.4 system to prevent equinus during stance and swing, and thereby ameliorates, reduces the hyperextension at the knee, producing a much more fluid gait, a more even step length, which is that. If we consider the biomechanics of what's going on, if you make initial contact with your forefoot first, then the ground reaction force is passing anterior to the knee joint and anterior to the hip joint. Therefore, you get the knee hyperextension and forward hip flexion. If you apply an AFO, indicated by this line here, then you can improve the posture of the lower limb to some extent. We brought the ground reaction force closer to the hip and knee joint, but we can improve things one stage further by the addition of a heel raise, which might be intrinsically part of the shoe. We can tilt the AFO anteriorly and thereby bring the ground reaction force just proximal, just posterior to the knee joint and slightly posterior to the hip joint. That has the effect of not only preventing knee hyperextension, but also increasing hip extension during gait, which has the effect of increasing step length. The other two types, as Winter classified, include equinus, and there may well be benefits from providing an AFO to prevent the equinus, to prevent progressive deformity. You are unlikely, however, in the presence of a purely stiff knee gait in a type 3, or a child with type 4 with knee and hip involvement, the provision of the AFO is not going to rectify their gait problem. As I say, it may well still serve a benefit in preventing progressive deformity. Of course, sagittal plane problems aren't the only difficulties that these children face. Hindfoot inversion with forefoot adduction related to overactivity of the tibialis posterior are frequently seen at the same time. The 3.4 system to prevent equinus is shown here with a lateral force counterbalanced by medial forces high on the shank, on the lower leg, and at the medial heel. And to some extent those forces can be applied during the measuring process, and we'll just consider briefly how orthoses are made. An impression is taken using a plaster of Paris to make a negative cast of the body. It's also helpful to measure the height that the AFO is going to be at this stage, and that cast is then removed. You'll see that it's quite a spectator sport on many occasions. That cast is then filled, and a pole is inserted to enable it to be worked on in the workshop. And the first stage is the imperfections need to be smoothed out. The pink areas that you can see on the cast on the right hand side is a colour that's been added so that we can distinguish what plaster we've added and what we're taking away. And that produces a very smooth cast. That's then inserted into this tube, which is attached to a pipe going to a vacuum. We then lay a sheet of very hot plastic over the cast, make a seal along the bottom, including that tube, and then the air can be sucked out, producing a very tight fit over the cast. And that then needs to be left for 20 hours or so to cool into that shape. That plastic shell is then removed, and then we come to the very important part of the addition of the straps. Now you've seen that you need the strap over the instep to retain the heel in to prevent the equinus. You can also use different strapping methods to prevent valgus or varus. And one that we favour in Oxford is the stitcher strap in the instep, in the arch area, and that then spirals around the leg and fastens around the back. And that creates, in addition to the prevention of the hindfoot inversion, a supinatory component to correct the foot and hold it securely in a neutral position. Two other techniques that I've admired from around the world is one on the left there is from our colleagues in Canada who mould this leather over the cast to create a close fit, and our colleagues in Holland who create this wonderful leather bootie. Far too time consuming, in my opinion, but a work of art. So as well as controlling the hindfoot inversion, we want to control the forefoot adduction component. And we do that applying a medial force on the heel and the forefoot, and a force laterally just behind the base of the fifth metatarsal. Now the forefoot force can be applied just by using the internal part of the shoe, but in addition, if required, if the deforming forces are so great and require it, we use elastic Velcro straps that can form over the body and don't exert any excessive pressure. Of course, on many occasions we come across children who, for whatever reason, have a fixed equinus deformity and are not appropriate for surgery, or it might be while they wait for the surgery to take place. And in those circumstances, you can improve a child's stability by accommodating the equinus, shown here by addition of rubber underneath. All the technical skill in the world to make a well-fitting AFO with the best straps is lost unless the family are instructed to put the orthoses on correctly. And so we really show families this and the family includes any carer or helper or teacher that's going to be involved in the taking on and the putting off of the orthosis. So the first thing we demonstrate is that the foot is more flexible when the hip and knee are flexed to a right angle. You then need to correct the forefoot in the inversion or eversion, and hold the foot in the position the orthosis was made in. The orthosis can then be introduced from the back. Once on, holding the foot and the orthosis securely, and some families are surprised how hard you have to hold it, the instep strap then has to be fastened sufficiently tight that the heel can't rise out of the back of the orthosis. The orthosis is not a very clever device. It's very crude. It only knows one position. And if the foot and the ankle are not introduced into that position, then you're more likely to get rubs and problems. The fact that the orthosis provides total control for the foot and ankle precludes the need for any specialist footwear. And we therefore encourage families to anything that's light and flexible with a non-slip sole. The next question the families ask is, how long should we use the orthosis for? And it's very difficult to answer. We'll quite confidently say you should use it between 6 and 8 hours in every 24 hours. And we make that recommendation based on the work of Tardieu, who looked at for how long the soleus muscle should be stretched, or how long the soleus muscle was stretched in children who didn't develop deformities. However, as we've heard from others this morning, it's really the gastrocnemius muscle that is quite often spastic, and that covers not just the ankle but the knee joint as well. And therefore our recommendation can't be so concrete. I think we really make it as a piece of advice. As we've said, children with hemiplegia, GMFCS levels 1 and 2, they can get around and do all the things they want to do, and they may well be rather self-conscious of using the orthosis and say, well, can't we use it at night? And frequently we do say, yes, you can use the orthosis at night, but we understand that because the knee is not going to be fully extended at any time during the night, because clearly none of us could sleep while we were being stretched, that nighttime use is nowhere near as effective as daytime use when each step provides an active knee extension moment and stretch on the gastrocnemius. As the children are so active, they would normally take them off for sports, unless for any reason on an individual basis they would prefer to use them. Hinged AFOs are something that frequently come up, and I saw them on a previous slide based on the recommendations of Kurt Graham and his classification system. However, perhaps a bias of the children that come to our centre, which is a tertiary referral centre, we see very few children who fit the criteria for this device. Now the reason for that is if they have a full range of movement, then they're often a type 1, and they can get away with a device that's much less bulky by using a posterior leaf spring. If they don't have the full range of movement and they can only get dorsiflexion to plantigrade, then the hinge is actually going to reduce the efficacy of the device on stretching the gastrocnemius. You need knee extension, and if there's tightness, be it fixed tightness or tightness due to spasticity arising during gait, then the ankle will dorsiflex before the knee gets to extension. The third reason that we very rarely use a hinge device is because if you have inversion as well, it's very difficult to distinguish in the orthosis allowing dorsiflexion without permitting also the inversion for the most part, or alternatively any sort of planar valgus element that can also arise. So for this reason, we understand that there are children who may benefit from hinged AFOs, but on a day-to-day basis we find very few that we actually prescribe them. Apart from the posture of the foot and ankle that can be controlled using an AFO, the other part that orthotic management can play is the limb length discrepancy that arises due to undergrowth of the impaired limb. Now, to some extent, you can include an insert inside a shoe, particularly if required for tuning the ankle foot orthosis to realign the ground reaction force. But anything more than a centimetre usually has to be fixed on the outside of the shoe, and that can be done fairly aesthetically, so that it's hardly noticeable. The important part of adding the raise is that extra material will stiffen the shoe, and therefore should be tapered off quite sharply so that the heel can rise in what we saw in the previous presentation as the third ankle rocker. Of course, even the best orthotists face problems on occasion. You've made the orthosis, you've instructed the family on fitting it correctly, and still you get rubbing problems, particularly over the bony prominences such as the ankle, the Hmiplhgikh, the base of the fifth metatarsal. And in these instances, polypropylene is quite a versatile material, and it can be heated just locally using a heat gun, and then an allowance can be made just for that bony prominence. However, on occasions, and particularly when the rubbing is at the back of the heel, it's often due to the fact that the orthosis is trying to achieve something that it really can't succeed in. There isn't sufficient range of movement in the calf muscle to allow the AFO to control it. And in those instances, it's often not necessary to modify the AFO, it's necessary to attempt to modify the limb, and using serial casting to increase range of movement with or without botulinum toxin is often a first step. Now, in 2002, I reviewed the literature regarding whether AFOs were effective in improving function or preventing deformity for children with cerebral palsy, not just those with hemiplegia. And we found just under 30 studies that were mainly small within subject comparison studies that had used gait analysis to look at the effect of the AFO. Now, what that shows us, and the studies included nearly 500 children, is that preventing plantar flexion has some benefit. What we don't know is, from any of the literature, is whether an AFO has any benefit in preventing progressive deformity. And that's because we haven't really studied the children over a sufficient period of time. Now, I first became aware of that problem 10 years ago, and it's my fault, as well as many other people's, that we didn't start following the children back then, because by now we probably have some better idea. And what's interesting to know is whether I'll still be giving this same slide in 10 years' time. Well, what we know is preventing plantar flexion during gait can improve all the prerequisites of normal gait. An AFO preventing plantar flexion can improve stability and stance, can help clearance in swing, stance-based prepositioning, increase step length, and improve energy expenditure. Now, it doesn't do that for all children. As we've seen, children with type 3 and 4 hemiplegia aren't going to get those benefits. Okay? So there's still further research that's necessary to define for which children these benefits truly occur. Now, I focused almost exclusively on the lower limb, but we shouldn't rule out the fact that children with hemiplegia have problems with the upper limb as well. So just a quick consideration of that. As I said, the gross motor function classification system, published in '97, is now cited in almost every publication about children with cerebral palsy. And we're about to see the inception of the manual ability classification, which has been accepted for publication in developmental medicine, and it was developed by Eliasson and Son et al. And that's based on the same construct as the GMFCS, whereby children in level 1 can do everything of their age-matched peers, albeit that they have cerebral palsy and perhaps hemiplegia, whereas level 5 children can't perform any of those activities at all. And I think we'll see an increase in the use of this in the next few years. As far as the orthotic management of the upper limb, for those children who have the potential to develop functional skills in their impaired hand, providing some extension of the wrist is often beneficial. And that requires a similar process as I showed you for the lower limb, starting with a negative cast. And the best The better the position that's achieved during that casting process, the more likely the child is to get benefit from the orthosis without it causing any problems. So to sum up, the ideal orthosis replaces function, is weightless, invisible and costs nothing. That was a nice summary that was included by Lenheis back in '93. And as a conclusion to this talk, for children with hemiplegia who are really quite functional, and it's often the way they carry out activities rather than whether they carry out the activities, I think we should beware of the opposite problem. And that would be providing equipment that actually makes life more difficult for them, is unsightly and costs a lot of money. Thank you.
Something else? That's question number one. And second is, how do you measure patient satisfaction, either with orthosis with the upper extremity or the lower extremity? Because we often, very often have the case where the doctor is happy, the therapist is happy, and the patient is very unhappy.
Okay, well the first question, as I understand it, was how to measure outcomes for the upper limb.
Yes.
And I think how we do it currently is to do it on an individual basis as to whether the children can perform a specific activity, so a sort of goal attainment type of scaling. However, one has to recognise that that's not very useful, that you can't aggregate goal attainment scaling outcomes. I'm aware that there's a measure that's been developed in Belgium, I believe, called the Abel hand, and that may well, that's sort of modelled on a sort of GMFM type linear scale, so that might help in that respect. Your second question was, correct me if I'm wrong, if the doctor's happy, the therapist is happy, and the child is unhappy. Was that the correct?
Do you have a way to measure patient satisfaction with orthosis of lower limb or upper limb?
Ask the patient, ask the child. Children are very, sorry? No?
In real life, it might not be that easy because, I mean, I'm talking about objective measurement. I'm not talking about just, okay, ask the child, obviously, the child might not be happy with wearing whatever orthosis, but there must be another way to, other than just asking, are you happy with it? There's something formal, in other words.
Yeah. I think this is a very personal view, but I believe in a very family-centered approach to providing care. And something can be technically right from a biomechanical point of view and be discontinued. Because with the best will in the world, unless the child wants to use it, and they have every right to consent. There was some work done in the UK about the competency of children to consent to treatment, and children as young as 6 or 7 years of age are very competent in making their own informed decisions. As I've pointed out on a couple of occasions, particularly with the lower limb, we don't make children walk much better or further, we just make them walk different, and particularly on a flat surface. Now if we then take the child outside into a playground with an assault course with lots of things to jump over, they might actually find it more difficult to do those activities wearing their orthosis. And they have every right to self-determination. So I think, particularly with orthoses that are rarely life-saving, we offer treatment, and it's up to the child and family whether they take it on board and use it. And it's really the family that knows the child across a greater number of environments than the health professional, because whenever I see a child in hospital, it's a flat surface, no problems. If I see them in school, it's adapted, there's ramps. It's the family that try and get the child around the shopping centre to the airport to do all the things, the other activities they do in their life. And whilst I agree it's not, necessarily a reliable outcome, it's the child that lives the experience, and so it's they are the best reporters of whether or not they're satisfied with it.
Mooi, κύριος Δημητριάδης. Εδώ δεξιά κυρία, ο κύριος.
Thank you. In my experience, children with cerebral palsy are not compliant with any type of orthosis, any type of braces. And this is because any orthosis does not diminish the muscle stretch reflex. Therefore, a lot of the kids take their orthosis off, or they develop, if the parents persist, they develop pressure sores very quickly. Now that's for children who are not operative. Post-operatively though, the majority of them are tolerant to the orthosis, and they are much more compliant. My first question is, what's your experience about that? The second question is for wrist. Normally, in cerebral palsy, the wrist is in flexion and pronation. If somebody tries to get the mold in a wrist extension, then the child cannot extend the fingers because the flexors are too tight. So what we normally do is we take the mold in wrist neutral position. What's your experience?
The first one regarding tolerating an ankle foot orthosis, we do see children that get skin breakdown and rubs, and as I said in the troubleshooting slide, often it's then necessary to seek another level of intervention, be that serial casting to increase range of movement, botulinum toxin, or indeed surgery to cranial lengthening or such as procedure. So I would agree that in certain circumstances that's required, but I would take the opposite view that that's not my complete experience. Not every child who's required with an AFO gets those problems. I think there's a spectrum of difficulties along. At some point there's a threshold. Children get, an orthosis isn't the sole solution. But there are many children that we see who use an AFO from day to day who actually want to use it because they feel it does provides some benefit. With regards to your second question on the wrist and hand, again, it's a spectrum of problems. I showed you a slide of one device, which is a very functional device, which is aimed to help handle objects, and therefore extending the wrist allows the same muscles which are struggling to extend the wrist and manipulate the objects. We've solved half the problem by extending the wrist, and the children can then focus their concentration on using their fine motor control to grasp the object with their fingers. I would agree that if you had a child with a more severe problem and tighter flexor muscles, then that may not be possible. And what we might use in that instance is not a functional orthosis, but an orthosis that actually is more like a paddle that comes to the end of the digits to actually stretch those muscles, if that was a treatment goal that the family wanted to pursue.
Two comments. One for the first question we had from the lady. In response to her question about what do you do when you don't have very good patient satisfaction or very good compliance, I would like to perhaps share some of my experience that the gait analysis can help in this way, but because if you do show the results of the gait analysis before and after, often, not always, but sometimes, it does persuade the parents and sometimes even the child that yes, there is a positive effect in feedback way by just seeing these results. So this is my first comment. The second one is, since you mentioned that the ideal orthosis is weightless and also replaces function, do you have any experience of using functional electrical stimulation, especially for the lower limb, and also of these elastic lycra type orthosis for the upper limb?
It's quicker to answer the second point first than to say that I don't have any experience with functional electrical stimulation. I know personal experience of prescribing lycra garments, but I have seen children with them, and one of the few parts of the body I've seen families persist in their use is for the wrist and hand. I haven't been able to discern any effects with and without, but there seems to be compliance in that respect. I've certainly seen better compliance than any light-pursuits provided for the whole body. As regards your first point, I'd entirely agree. I think the more feedback that you can give families about, and the child, about why you're providing a certain form of treatment, and for the child to see that they walk with a different pattern and perhaps more like their peers, using the orthosis than without, I think that would be a really useful outcome. And I don't think you need a complicated gait laboratory. A simple video would be enough to do that. So I'd completely concur with that.